Is that working? Yes, fine. First, I'd like to thank the forum for coming around to the issue of mental illness and violence. I think it's clearly an issue that's time has come, and it is, as Mark mentioned initially, it's a sticky wicket and there's a lot of political ramifications, but it really is necessary to start shedding some more light and a little less heat on this very important issue. I'm going to talk about means restriction, about pesticide ingestion. And first, the topic, I'm going to cover 4 topics. First, background on suicide and pesticide ingestion. Look at the characteristics of this in China. Talk about means restrictions generally as one of the interventions to try and prevent suicides. A little bit of the lockbox project that I've done in China. And then a final question, final issue about issues that some of this raises for low and middle income countries. Okay, background on suicide and pesticide ingestion suicides. This is results from the recent global burden of disease study showing where does suicide fit in the big violence picture. And this is globally, you can see that suicides, this is a proportion of all violent deaths, which includes interpersonal violence, war, executions, and suicide. The proportion are due to suicides. Globally, in males, it's about I can see it better here. In males, it's about 60%. In females, it's about 75%. That's globally. If you look at high-income countries, more than 80%. So more than 80% of violent deaths, males or females, are suicides. Only 20% are interpersonal violence or other things. In developing countries, it varies a little. These are low and middle-income countries. Oops, sorry. Can I go back? Okay. In the sub-Saharan Africa and particularly Latin America, where suicide rates are relatively low and interpersonal violence is relatively high, suicide is proportionally much less important in terms of overall violent deaths. However, in other developing areas, Asia, South Asia, and Central Europe, suicides are still much more than half of all violent deaths. So it gives you perspective where suicide fits into the overall violent death globally. Of these suicides, 84% occur in low and middle income countries. So only 16% happen in high income countries. And of course, almost all the research, almost all the ideas about what we're supposed to do about it, almost all the models about what suicide is, come from these 16% of countries. And so the question is, how relevant is what we find here for what happens here, which is where 84% of the suicides happen. In fact, India and China account for 56% of all male suicides globally, and for 61% of all female suicide globally, just those 2 countries. And suicide in India, this is a recent publication in The Lancet, about 50% are poison, almost all of those of which are pesticide, both in males and females. So the vast majority of suicides in India use pesticide. In China, this is a study that's a little old now, but it's again well over 50% of suicides are due to pesticide or to rat poisons. So it's poisoning by very lethal means. So in those 2 countries that account for the majority of suicides in the world, pesticide is by far the #1 cause, method. So a review by David Gunnell looking worldwide, because in fact World Health doesn't have good data on many of the developing countries in terms of methods, estimates that about 300,000 suicides a year, about a third of all the suicides in the world, are by pesticide, which means globally pesticide is by far the most common method of death by suicide. And interestingly, it's not the amount of suicides in the country. In fact, the amount of pesticide, the pesticide per capita in the United States is higher than it is in China, but it's almost never used. So it's actually the way the pesticide is used, who's using it, where it is, that really determines whether or not it's going to be an implement for suicide. And in China, 75% of the suicides are stored in the home. 58% of the suicides are category 1 organophosphates, which are the most potent versions. Suicides, pesticide, of course, there's those that are more or less potent. They have very different effects. But the most potent kind are the ones that cause most of the suicides. And 62% of them receive medical resuscitation before they die. So they got to medical care, but they still die. And many of the attempts also, those who come to emergency room and survive, about over a quarter of the attempts in China are use pesticide. Again, they're stored in the home. So it's not something that people go out to buy to commit suicide. It's just there so they can pick it up whenever they want. And most of them are using the category 1 organophosphates. So given the public health importance of this problem, we know surprisingly little about the characteristics and prevention of pesticide ingestion suicides. It's only the last 10 or 15 years there's actually been any focus on this, because all the attention was in guns and other things that were happening in Europe and America. It's only recently, over the last 10 or 15 years, that it's realized that it's the #1 method of suicide globally. So what are the characteristics of these pesticide ingestion suicides? Well, this is as you would expect. Here we're looking at, this is in China, completed suicide and attempted suicide. And as you would expect, those who live in rural areas are much more likely to use pesticide than those who live in urban areas. And again, those who attempt suicide, those who do not die, get to the emergency room, get treated, it's much more commonly that they'll be used pesticide if they're in rural areas, which is what one would expect. This is a very lethal means compared to other methods. So as I said previously, 62% of people who die by pesticide ingestion got to a medical practitioner, often a hospital, were resuscitated, but it still failed. Whereas any other methods of those who die of suicide, only 20% of any other methods actually got medical treatment, actually got medical treatment before they died. So compared to other methods, it's very lethal. And those who get to emergency rooms, who survive, who get to emergency rooms for treatment, 6% of those who go to emergency rooms using pesticide die, whereas any other method is only 1%. So relative to other methods, it's very lethal. This is a little complicated, but let me walk you through it. This compares those who made serious medical attempts who use pesticide and those who use other methods. Considered suicide for less than 5 minutes before the attempt. So the time between the first thought of suicide and when they acted was less than 5%. Those who use pesticide, 43%. Those who other methods, only 16%. This is pretty impulsive. I mean, 43% of the people who use pesticide to attempt suicide think of it for less than 5 minutes before they actually take it and drink it. Usually it's in the home. It's easily to get. They don't have to go out and buy anything. Other persons present, 30%, 31%, there's someone else there. So it's a social interaction. It's not I'm on my own, I got to get rid of I'm interacting, often in a context of interpersonal conflict, that if you don't do this, if you don't get rid of your girlfriend, I'm going to kill myself. And so there's sort of this event that's going on, and the drinking the pesticide is part of a social interaction. So and that's not somebody who really wants to die. Also, objective suicidal intent. That's the intent to die at the time. There's ways to measure this by how it's done. Is it done at night? Have they locked themselves? Are there other people around? There's a number of factors you can assess. And based on that, persons who use pesticide, 49% have high intent, whereas those who don't, 70% have high intent. So we have this mix. We have a highly lethal method, but people are less determined to die. So it's low intent and highly lethal method. So it doesn't, we usually think that people who want to die, who are more intent on dying, are going to use more lethal methods. But in fact, in this setting, it's the opposite. Those who are less intent on dying are using a more lethal method. Mental illness. Only 33%, 1/3 of the people who ingested pesticide actually had a current mental illness, whereas those who use other methods, 54% had a current mental illness. So they're less likely to be mentally ill. So this is a really unique group of people who are using this very lethal method, the most common method in the world, to kill themselves. And indeed, studies from China dispute some of the common knowledge in the West that everybody who has made an attempt to kill themselves is mentally ill. Our data, this is an attempt suicide, say that 60%, more than 60% of people who attempt suicide do not have a mental illness at the time. Now, my colleagues Eric and others from the West say it can't be true, you missed it. Well, this has been repeated in multiple studies now. Many people who attempt suicide in China, it's very impulsive. They don't have an ongoing mental illness. It's been going on for a long time. Often it's, as I said, 5-minute event. So a substantial proportion, of course they do, there are those with mental illness, but a substantial proportion do not have a mental illness at the time of the act. When you move to completed suicide, this is those who die of suicide. Now, this is a national psychological autopsy study I did about 15 years ago. It's a little old now, but at that time, using very detailed methods. About 30% of people who died of suicide did not have a mental illness at the time. So this is really a very different context than what we usually believe from the West. How representative this is of other developing countries, it's hard to say, but really requires a different perspective on thinking about the problem. Okay, in terms of pesticides, this is a study I did nationally looking at availability of pesticides in the household by region and suicide rates by region. And it's clear that regions in which, these are rural areas, in which households have pesticides stored in the home, the suicide rate is higher. So it's like gun availability. This is on a national level. So areas where pesticides are more commonly held in the home have higher suicide rates than those where pesticides are less commonly held in the home. Well, what's happened with China? China's been urbanizing incredibly rapidly. China now is more than 50% population urban. So over the last 20 years, the proportion of the population living in urban areas increased dramatically. And at the same time, those in the rural areas who still work in agriculture, because rural areas also have small factories and stuff, has gone down dramatically. So there's a lot fewer people who have pesticides in the home because people are moving to cities, and those who live in the countries no longer work in agriculture. What's happened to the suicide rate? It's dropped by 50%. There are now 100,000 less suicides a year in China than there were 20 years ago. If you realize there's only 800,000 suicides in the world, that's a huge drop. Now, I can't prove that's because of changes of access to pesticide, but I'm convinced it's one of the major factors. Of course, many other things happen, economic development, et cetera, so there's a lot of factors there, but I have no question in my mind that decreased access to pesticide on a daily basis is one of the major drivers of this huge drop in the suicide rate. So the hypothesis from China is that most low and middle income countries with large agricultural populations, patterns of pesticide use and access to pesticides are more important determinant of the rates and demographic characteristics of suicide than the prevalence and treatment rates of mental disorders. What this means is what we need to do: first, ban the most toxic methods, decrease access to pesticides in the home, do community education, and improve training and the services available in the medical centers that are treating these people. Pesticide resistance is very hard to treat. Very often it's extremely difficult to treat. You need high quality equipment and clinicians, and that's often not available in rural areas of China. But those are clearly interventions we should do. The WHO had, I worked with Michael Edelston and others to develop clinical management guidelines for emergency rooms in rural areas to try and improve their success rate in dealing with pesticide management. Of course, different pesticides have very different effects, and so you've really got to be pretty sophisticated in dealing with it. Okay, means restriction. So one of the things is improve the medical treatment, but the main focus should be on means restriction. Well, as we talked about earlier, means restriction is just one of the many steps one can do in trying to prevent suicide. And the relative importance of means restriction as a suicide prevention strategy depends on a number of factors. It's a little complicated, but within a community, the overall suicide prevention strategy depends on the proportion of suicides by ingestion, jumping, firearms, charcoal, or so forth, which are amenable to restriction, and versus hanging, which is less amenable to means restriction, other than the hanging in hospitals. In hospitals, you can prevent by actions, but hanging in the community is very hard to prevent. So what is the relative importance of those methods in your community? That will determine how much emphasis you put on means restriction. You need to monitor the methods of suicide in different demographic groups, because it varies, and by age, gender, and subcultural group. There are several examples of relatively rapid change in methods used in community, like charcoal burning in Hong Kong. So ongoing up-to-date information on methods employed in fatal, non-fatal suicide behavior is needed, because you got to respond to the changes in methods that people are using. There's a number of factors that influence the effectiveness of a particular means restriction method. How much substitution is? Did they go from one chemical to another? And in Sri Lanka, we limited access to one chemical, and then they started using a plant which is actually more lethal. So if the substitution is a more lethal method, that's going to be problematic. So you have to watch this over time. Proportion of impulsive suicidal behavior. If a lot of your suicidal behavior is impulsive, restrictions of means would be much more likely to be effective. So that can change. That's different in your age groups. Access and coverage of emergency psychological service. If you prevent them from trying, do have some support you can give them. If you don't, then the prevention, they're going to try again. Access to effective resuscitation methods, which I said in pesticide is a particular problem. So these mediating factors can also change over time. So they need to be assessed and monitored in parallel with the methods people are using. See what method is most likely to be most effective at what time. This is as an example of Sri Lanka, where they, because Sri Lanka is an island, they were able to completely restrict the importation of high toxic pesticides. The suicide rate dropped dramatically. So where you can really restrict it, you can limit it. You say, we're not going to sell this chemical anymore. There's some countries where you have complete control, where you see dramatic drops in suicide when you restrict one particular pesticide. Other methods you can use, promote storage in homes, establish a minimum pesticide list so you only can have certain pesticides, promote integrated pest management, which basically decreases the overall use of pesticides, apply a tax to pesticides, increase with pesticide lethality, limit usage of pesticide in each village or community to a small number of people. So not every household has it, but there's a couple of people actually applied the pesticide to the fields. Train pesticide retailers to recognize potentially suicidal individuals, and limit the amount that you can sell. So you'll limit the amount that's usually a one-day amount rather than you buy a month's supply so it's stored at home. The WHO has a number of booklets that I've been involved in talking about community interventions to develop storage methods. I'll talk about a method that we've developed in China in a project that I worked on. So this is one of the projects following the WHO pattern of restricting means. The objective of the project was to choose a couple of counties, a couple of townships within a county. It's in Shanghai province. Install 10,000 lock boxes. You lock the pesticide in a box, so it's locked, so therefore it's a little less accessible. Provide educational campaign, monitor compliance, and then compare the before and after suicide rates to see, does this limitation method actually have any effect? This is where it was in Shanxi province. This is the county, and we chose 2 townships that had 11,000 households and compared it to the other townships within this county. This is the usual storage method in the countryside. Just put it in, this is in the person's home. Typically, pesticides are supplied in concentrated methods, so you add a lot of water before you actually apply it to the field. And it usually stays in the home around the year. This is our lockbox with our suicide number on it. And then here it is locked up. Of course, right after we bought 10,000 of these boxes, we realized that it wasn't big enough. You just, a lot of pesticide are in bigger containers than we thought. We followed people over actually 5 years, but this is 3 years data. Look at the lines here. So we initially gave them 2 keys. The idea was the husband and the wife both had to be there to open it up, 2 keys, 2 locks, so that would sort of guarantee it. None of them really bought this. You know, they didn't really buy this as something to do. So basically, nobody used our great idea. This is initially 7 months after, so we had about 30% take-up. And people were using the box, but most of them were not using the locks. The first 2 years, this seemed pretty stable. 20 to 30% people were actually locking it up. But then our psychoeducational intervention stopped, and immediately the use of the lock dropped. People kept using the box. About 88% were using the box, but almost none of them were locking at the end of the 3 years. So when you stop your educational intervention and sort of promotion of the box, people stop locking them up. That was their experience. The suicide rates actually dropped pretty dramatically. Now, there was a problem. The communities we chose had higher rates to start off with, but overall, this is a before and after program. In our intervention sites, the medically treated attempts to suicide dropped by 23%, whereas those in the control sites went up 2%, and the pesticide ingestion rate, this is the rate, the change in rate, dropped by 23%. So it's pretty good. Okay. So my impression from the study, it's unrealistic to think that you're going to have 100% compliance with these types of programs. But understanding the reasons, the factors that will influence people to actually use the lockboxes, these storage projects, is really essential. And applying those over time, you can't just do it one time. It's got to be an ongoing process. Of course, you have to think of the potential danger of having the pesticide in a highly visible, accessible location. If it's unlocked and it's there, it makes it even more visible. So that could be a downside of having these lock boxes. But means restriction needs to be part of an overall suicide prevention strategy, not a standalone program. It's not something just do and don't do. It's part of an overall suicide prevention plan. For example, this is our national plan, our attempt to get a national plan. It's never happened. Decrease access to lethal means, suicide, particular pesticide. It's just one of a whole range of interventions you need to do. Okay, finally, tough questions for suicide prevention in low and middle income countries. These are my questions. I'll just come to the final message. Every country will need to make its own decisions about how to mobilize and expend personal resources, personnel, funds, and other resources for prevention of suicide. In the Chinese setting and in many other low and middle income countries, putting all your resources on individual mental health approaches is probably not the best bang for your buck. If your goal is to reduce suicides, this, in my view, is not where we need to go. I think certainly improving mental health service is essential. In and of itself, it's a good. But if the goal is to decrease suicides, you probably get a better bang for your buck if you don't have many bucks by doing means restriction, particular pesticide in rural areas. Thank you very much.
Thanks, Michael.